Welcome. Today we are moving beyond the standard NRP algorithm to talk about resuscitation in special situations, the high-risk, low-frequency conditions that don't follow the script. Every neonatologist knows the standard algorithm cold, but a subset of deliveries present with anatomy or physiology that make the routine steps ineffective, or in some cases, actively dangerous. This is a tactical playbook, a rapid reference for the delivery room, organized around three anatomical zones: airway, thorax, and abdomen, plus the systemic conditions that don't fit neatly into any one compartment. Let's get into it. Here's the core premise of this entire lecture. The standard NRP algorithm assumes a structurally normal newborn. In special situations, that assumption breaks down. Steps we perform reflexively, bag mask ventilation, standard supine positioning, can cause active harm, sometimes before we've even delivered the first breath. The single most important mitigating factor is anticipation. Most of the conditions we are covering today are diagnosable antenatally, on routine ultrasound. When the diagnosis is made ahead of time, we convert a chaotic, reactive emergency into a planned, controlled resuscitation with the right team and the right equipment already in the room. A missed prenatal diagnosis is what turns this into a crisis. So as we go through each condition, keep two questions in mind. What would I anticipate if I knew this diagnosis in advance, and what does the standard algorithm get wrong here? We are going to organize special situations into 8 categories. 4 of them are structural, working roughly head to toe: airway malformations like Robin sequence and choanal atresia; air leak, meaning pneumothorax; thoracic compression from congenital diaphragmatic hernia; and effusions and hydrops, fluid crowding out lung and heart function. Moving further down, abdominal wall defects, gastroschisis and omphaloceal, and neural tube defects, specifically myelomeningocele. And 2 categories are systemic rather than anatomic: extreme prematurity, at the margin of viability, and maternal factors, medication effects that cross the placenta and depress the newborn. We'll take each of these in turn, focusing on the mechanism, the diagnostic clue that tips you off, and the tactical pivot away from standard technique. Let's start at the airway, with 2 conditions that look similar on the surface but need different fixes. Robin sequence first. The mechanism is micrognathia and glossoptosis. A small jaw lets the tongue fall back and obstruct the pharynx. The tactical pivot is positioning. Place the infant prone or lateral, and insert a nasopharyngeal or oral airway to hold the tongue forward. If intubation proves difficult, and in these infants it often is, escalate to a laryngeal mask airway rather than persisting with direct laryngoscopy, which is going to be a genuinely hard view in this anatomy. Choanal atresia is different: bilateral bony or membranous obstruction of the posterior nasal passages. Remember, newborns are obligate nasal breathers, so this is a true emergency. The diagnostic clue is classic and worth memorizing. The infant is pink while crying, because crying opens the mouth and bypasses the obstruction, but cyanotic at rest. You'll also be unable to pass a catheter through the nares. The fix is straightforward once you know it. An oral airway, or an oral endotracheal or McGovern-type airway, bypasses the obstruction entirely. Same region, same sounding presentation, opposite airway strategy, which is exactly why anticipating the diagnosis matters. Congenital diaphragmatic hernia. The mechanism: abdominal viscera herniate into the chest cavity and cause pulmonary hyperplasia. The lung on that side simply never had room to develop. Suspect it clinically from a scaphoid abdomen, unilateral absent breath sounds, and, the telltale sign, bowel sounds auscultated in the chest. Now, the management here is where standard NRP training can actively work against you, so listen closely. What to do? Intubate immediately. Place an orogastric tube on continuous suction to decompress the stomach and bowel. Use highly gentle ventilation pressures throughout. What to absolutely avoid? Never use bag mask or CPAP ventilation in a suspected CDH. Positive pressure by mask distends the bowel that's sitting inside the chest cavity, and that actively worsens the lung compression. This can be fatal. Also avoid high peak pressures given the elevated risk of air leak in that hyperplastic lung. This is one of the clearest examples in the entire lecture of the standard algorithm's first-line intervention being the wrong move. If you know CDH is coming, go straight to the endotracheal tube. Pneumothorax doesn't usually announce itself in advance. It's a complication you react to, often during or immediately after positive pressure ventilation. The trigger is sudden deterioration, bradycardia, desaturation, or loss of chest movement occurring during or after PPV. On exam, look for asymmetric chest movement, decreased breath sounds on the affected side, and displaced heart sounds. Transillumination will be positive on the affected side. The intervention is immediate needle or catheter decompression if you see tension physiology. And here's the critical operational point. Do not delay decompression for X-ray imaging in a rapidly deteriorating infant. Clinical diagnosis takes priority. If the baby is crashing and your exam fits, you treat. You don't wait for confirmation on film. Hydrops and significant effusions represent a genuine multisystem collapse, so this is where you need extra hands in the room, not just a different technique. The context: abnormal fluid accumulation in 2 or more compartments, pleural, pericardial, and ascites, heavily restricts both lung expansion and cardiac output simultaneously. 3 systems need simultaneous attention. Airway: anticipate exceptionally difficult ventilation. Early intubation is almost universally required. Don't wait to see if the infant self-corrects. Drainage: simultaneous thoracentesis or paracentesis is often required just to permit lung expansion, so that equipment needs to be pre-staged before delivery, not fetched mid-resuscitation. Circulation: severe underlying anemia is common. Have emergency release, cross-matched blood ready, but avoid indiscriminate volume boluses if you suspect underlying cardiac dysfunction, since these infants can decompensate with fluid overload just as easily as with hypovolemia. This is a condition where you genuinely cannot manage it with a single resuscitator. Call for backup before delivery, not during it. Gastroschisis and omphalocele get lumped together because they're both abdominal wall defects, but they need distinctly different handling. In gastroschisis, the defect sits lateral to the umbilicus, and the bowel is exposed with no covering sac. The primary action is to place the lower body in a sterile bowel bag or plastic wrap immediately. This is about preventing massive heat and fluid loss from that exposed bowel surface. Secondary considerations: avoid any traction that could kink the mesenteric blood supply, anticipate high-flow fluid requirements, and place an orogastric tube for decompression. In omphalocele, the defect is central, at the umbilicus itself, and the viscera are contained within a membranous sac. Here the priority is the opposite of gastroschisis in one key way. You cover the intact sac with a sterile, moist, non-adherent dressing, and you handle the infant with extreme care to avoid rupturing that sac. Omphalocele also carries a high association with other anomalies, cardiac, chromosomal, and Beckwith-Wiedemann syndrome, so a broader anomaly screen is warranted. Orogastric decompression applies here too. The one-line differentiator to remember: bowel bag for gastroschisis, protect the sac for omphalocele. Myelomeningocele requires us to invert our usual resuscitation workspace, because the defect is on the back, not the front. The positional pivot: standard supine positioning is contraindicated. Position the infant prone or lateral to avoid any direct pressure on the exposed sac. If chest compressions become necessary, the sac needs to be supported off the bed rather than compressed against it. Sac protection: cover it exclusively with a sterile, moist, non-adherent dressing, nothing dry, nothing adherent. And one absolute contraindication that deserves its own call-out: latex. There is a well-documented high association between spina bifida and latex allergy, so strictly latex-free equipment must be used for these infants, not just during this resuscitation, but going forward throughout their care. At the margin of viability, the special situation isn't a single anatomic lesion, it's the entire physiologic system that hasn't finished developing. This unfolds in 3 phases. Phase 1, antenatal counseling, a joint discussion between obstetrics, neonatology, and the family establishes the goals of care, and this conversation determines whether resuscitation will even be attempted. This has to happen before delivery whenever possible. Phase 2, environmental preparation. Radical thermoregulation is the priority: a warmed and humidified delivery room, an occlusive wrap, a thermal cap, and a thermal mattress, all active from second 0. These infants lose heat catastrophically fast, and hypothermia at this gestation carries real mortality risk. Phase 3, golden hour execution. Gentle, precise technique throughout. Lower initial inflation pressures and careful, oximetry-guided oxygen titration to prevent tissue injury from both under- and over-oxygenation. The theme across all 3 phases is precision. This is not a resuscitation where you improvise pressures or timing on the fly. 2 maternal medication exposures deserve specific mention, because they present similarly: a floppy, underbreathing newborn, but are managed differently. Opioids, from maternal administration, cause neonatal respiratory depression. The action is to support breathing with positive pressure ventilation and treat it strictly as a ventilation problem. Here is the critical safety point of this slide. Naloxone is not recommended for initial resuscitation, and it should be avoided entirely in infants of mothers with opioid use disorder because of the severe risk of precipitating acute withdrawal and seizures in that infant. This is a change from older teaching that many of us trained under, so it's worth stating explicitly: support with ventilation, not reversal. Magnesium sulfate, typically given for preeclampsia or fetal neuroprotection, causes neonatal hypotonia and respiratory depression as well. These effects are transient. Support with PPV. There is no specific reversal agent, so supportive care is the only mechanism available, and you should monitor for prolonged hypotonia as the magnesium clears. This last condition is the hidden variable, the one that doesn't announce itself with an obvious anatomic finding, and instead shows up as a resuscitation that simply isn't working. The clinical trigger: persistent cyanosis, shock, or bradycardia that does not respond to a well-executed standard resuscitation, hypoxemia that fails to improve despite adequate ventilation and 100% FiO2. Diagnostic clues to actively look for: weak or absent femoral pulses, differential cyanosis between pre- and post-ductal saturations, or a known history of cardiomegaly or arrhythmia. The immediate pivot is to order early echocardiography and get an immediate cardiology consultation, and to prepare prostaglandin E1 to maintain ductal patency for suspected ductal-dependent lesions. The teaching point here: if your resuscitation is technically correct and the infant still isn't responding, critical congenital heart disease needs to move to the top of your differential. Don't just keep escalating the same interventions. Let's bring this back to the theme from the start of the lecture: anticipation. For each of these diagnoses, when they're known antenatally, there's a specific team and equipment checklist. CDH, omphalocele, and gastroschisis need a surgical team on standby, with an orogastric tube, continuous suction, and a sterile bowel bag or moist wrap staged. Myelomeningocele needs neurosurgery awareness and strictly latex-free airway gear ready. Hydrops fetalis needs extra resuscitative hands for parallel procedures, plus thoracentesis and paracentesis kits and emergency cross-match blood products. Robin sequence and choanal atresia need ENT or anesthesia on standby, with a difficult airway cart and a range of LMA sizes and oral airways. And peri-viable gestation needs a documented family goals of care plan, along with occlusive wrap, thermal mattress, and precision pressure and oximetry gear. The pattern across every row of this table is the same. The diagnosis drives the staffing and equipment, and that only works if the diagnosis is known before the baby arrives. Let's close with the condensed version, the single deviation from standard algorithm that matters most for each condition, if you remember nothing else from this talk. Robin sequence: prone or lateral position, nasal or oral airway, LMA if intubation fails. Choanal atresia: oral airway required, because these infants cannot nasal breathe. Pneumothorax: immediate needle decompression if tension physiology is present, no X-ray delay. CDH: intubate immediately, absolutely no mask ventilation, continuous OG suction. Hydrops and effusions: early intubation, simultaneous thoracentesis, blood on standby. Gastroschisis and omphalocele: bowel bag for gastroschisis, moist dressing for omphalocele, avoid mesenteric traction, OG decompression for both. Myelomeningocele: prone or lateral positioning, latex-free equipment only. Extreme prematurity: aggressive thermoregulation, highly gentle and precise ventilation. And maternal opioids or magnesium, support with PPV, do not use naloxone routinely. That's the tactical cheat sheet. The standard NRP algorithm remains your default. These are the deviations you layer on top of it when the anatomy or the history tells you this isn't a structurally normal newborn. This material draws on the textbook of Neonatal Resuscitation, 9th edition, Lesson 10 on Special Considerations, from the American Academy of Pediatrics and American Heart Association, the 2025 AHA and AAP Neonatal Resuscitation Guidelines published in Pediatrics, and the 2025 International Liaison Committee on Resuscitation Consensus on Neonatal Life Support, also in Pediatrics. Thank you.